Okay, finally got ready. All right. I don't think I have any announcements this morning. I know I hear you guys talking about the nursing applications are due in 7 days. Well, actually, today's that makes 6. I don't know. But good luck. All right. And I know you're under a lot of pressure. So let's take a distraction from that pressure by talking about endocrinology some more. Okay. We left off talking about the hypothalamus. All right, five releasing hormones. We went through that. 2 inhibiting hormones. There's more than that, but this is enough for an intro to endocrinology. So now we're going to go from what the hypothalamus secretes here to what the anterior pituitary does in response. So that's the front part of the pituitary gland. So remember, the hypothalamus is the general. It's in control of everything. It controls the entire endocrine system. Whatever it does, the pituitary is going to take that order because it's the captain, and then it's going to secrete something in response to that. And more often than not, what it secretes will go to some distant endocrine organ and cause something to happen. All right, so the first hormone from the hypothalamus, and I use the acronym because I hate spelling it out. The GN, remember, let's see what my pen is doing this morning. Okay, the GN, what did the GN stand for? Gonad. So ultimately what this command is going to do is going to affect ovaries and testes. So when I said the brain controls everything reproductive, it does. Okay, so what the anterior pituitary is going to do in response to that is it's going to release 2 hormones that are going to go down to the testes and ovaries and cause them to do something. So it's going to release LH, which stands for luteinizing hormone. But remember, I like the acronyms, all right? And FSH, which stands for follicle. I think I got the U and the E mixed up. Sorry about that in the spelling. That's why I like acronyms. Just fit it in. All right, so 2 hormones. And then on the next slide, we're going to go over what those hormones cause to happen in the ovaries and testes. Okay, the next hypothalamic hormone is growth hormone releasing hormone. And so that causes the pituitary gland to release growth hormone, GH, which is growth hormone. Now, I talked last time, if you were here, about people abusing growth hormone. They can buy it. All right, you can get prescribed by a doctor. That means the drug has been passed through the FDA and it's approved, and if they're taking it as a prescription, their physician or physician assistant or whatever has talked to them about the dangers, the pros and the cons. But people who are buying this stuff off the black market, they don't get any such guidance or warnings. And so what did I say about some of the warnings of taking growth hormone? You remember that on Monday? They're pretty severe side effects that can happen. Anyone remember? Not louder because of the mask. Yes, if you're taking it as an adolescent, teenager, and your growth plates between your joints aren't fused yet, that growth hormone can cause them to fuse, which means you won't grow anymore. That's kind of counterintuitive if you're taking growth hormone. If your growth plates fuse, you won't grow taller anymore if they fuse, okay? The other risk is if you have precancerous cells in your body, growth hormone causes all cells to grow and repair. But if they get exposed to growth hormone, those cancerous cells can start growing out of control, and then you get a problem. And the other thing is, if you've got people who aren't finished growing yet, and they take growth hormone, just like abusing anabolic steroids, it can make you grow quite rapidly because you've got more of it in your body than you should. And at your joints, if you put on muscle mass too quickly or anything like that, it puts incredible strain on your joints. And you can have premature arthritis or joint damage when you're young, and that sucks, okay? So these are things to watch out for, because as nurses, I think you're going to encounter people who occasionally that abuse this drug, this thing. Okay, the C stands for cortex. Ultimately, it's going to affect your adrenal cortex. So what the pituitary releases is ACTH, which stands for adrenocortico. That literally means the cortex of the adrenal glands. Tropic hormone. That's a mouthful. This is why I like the acronyms. All right, adrenocorticotropic hormone. And we're going to talk about that because there's a lot of adrenal cortex disorders that are super common that you're going to see. All right, TRH. The T stands for, basically, it's going after the thyroid gland. So the pituitary responds by releasing TSH, which stands for thyroid stimulating hormone. It's pretty impossible to not guess what this is doing. It's going to stimulate the thyroid gland to produce thyroid hormones. Thyroid hormone disorders are so common that T3 and T4, which are two thyroid hormones, are included in almost every regular blood panel. That's how important they are. Okay, PRH. The P stands for prolactin, means prolactation. So it's going to affect the breast tissue. So the anterior pituitary releases prolactin if it gets that signal. Okay, think of it as prolactation. Okay, it will cause milk production. So the only time that the hypothalamus is secreting PRH and then the anterior pituitary is secreting prolactin is if a woman is in the later stages of pregnancy, usually around month 9, and certainly by the time, hopefully, the baby's born, it starts pumping out that hormone. Now, the inhibiting hormones. GH is for growth hormone, and so that's going to inhibit the pituitary, inhibits the pituitary growth, or I'm going to say growth GH release. It makes the pituitary stop secreting that. Because growth hormones have such a powerful effect, it has to have a check and balance system because of the things I talked to you about. All these hormones have to be within normal range. Too little is a problem, too much is a problem. So this is a particular thing. It's a check and balance to the amount of growth hormone in your body. The other inhibition is PIH, and the P stands for prolactin. And so when the pituitary senses this command, it inhibits prolactin. All right. So for most sexually mature women, you're under the influence of PIH most of your life. The only time that inhibition is lifted is when I said month 9 of gestation or after the child is born. And as long as a mother continues to nurse a baby, all right, then you won't have inhibition. What will happen is late pregnancy or when you're nursing a child, this rules and that rules. And as long as the woman keeps nursing, she'll keep having secretion of prolactin. Question. In the 2 feedback systems of the body, is this what I just described to you an example of positive feedback or negative feedback? Positive, because as long as the baby, now I talked about oxytocin. I said oxytocin is a milk letdown hormone, but this is also a positive feedback. As long as the baby's nursing, prolactin continues to be released. When she starts decreasing nursing or stopping altogether, she has a stop in prolactin secretion. That's positive feedback. Okay. So here are the effects of those pituitary hormones on the body. So all these hormones are receiving command from the hypothalamus. Then this secretes its hormones here. So prolactin, growth hormone, TSH, ACTH, and then FSH and LH. So we'll start at prolactin. Causes, basically, mammary glands will make their milk. Even though they produce milk, if the hypothalamus and its paraventricular nucleus doesn't release oxytocin, the milk won't leave the glands. That's just a weird hormonal thing. It's like oxytocin is permission for the glands to release the milk they've made. Kind of like insulin is the hormonal permission for cells to take in glucose. So the endocrine system is weird that way. Now, growth hormone causes most body tissues to grow and repair themselves. but it can be dangerous if too much is there. Now, TSH, thyroid stimulating hormone, of course, this is your thyroid gland, and it's going to produce T3 and T4, and you're going to see later on. It regulates your body's metabolism, how fast your furnace is running, so to speak. And women tend to have problems of low thyroid hormones, and men tend to have problems of high thyroid hormones. So we'll talk about hyper thyroidism and hypo, too low thyroidism, because they're so common. ACTH stands for adrenocorticotropic hormone. It's going to go after the adrenal cortex, and the cortex is the outer part of the adrenal gland. The inner part, I'll put medulla, is controlled by the hypothalamus in your fight flight. In your peripheral nervous system, and we'll talk about this, the adrenal medulla produces all that epinephrine that gives you that fight flight response. But ACTH causes production of small amounts of sex steroids. And I'll abbreviate amount with AMT. But cortisol is the main hormone that responds, the production of it responds to this. Cortisol. Anyone know what cortisol is? I had a clinical application reading for you in negative feedback in chapter 1. You may or may not remember it. You probably, if I were to sneak into your apartment or house the night before the first exam, you probably had screaming high levels of cortisol because it's your body's stress hormone. All right. And we'll talk about the effects of cortisol. It's also immunosuppressant. Okay. And the clinical app reading that you did in chapter 1, and we'll come back to that in this chapter. It's anti-inflammatory and it's also immunosuppressant, but it's anti-inflammatory. It's your body's natural anti-inflammatory. They have synthetic cortisols called glucocorticoids, prednisone, dexamethasone, and all those zones that people can take to suppress inflammation. But we're going to come back and talk about in a few slides. Negative feedback dictates when you take these drugs and levels of synthetic cortisol rise in your bloodstream, they get too high, right? The body wants to bring that down in negative feedback. So we've got to stop ACTH production. The hypothalamus will stop CRH production. And that's a side effect of taking synthetic steroids, and we'll talk about that. FSH and LH. FSH, follicle stimulating hormone. It will cause maturation of eggs and sperm. So that's what makes the eggs in a mature woman mature once a month. One egg is usually chosen. All right. And at sexual maturity, men produce sperm every day. LH, the ovaries will produce estrogen. Testes will produce testosterone. And down here, LH, a big surge in it mid-cycle, causes the ovary to ovulate an egg. So LH does a couple of things. Ovaries produce their hormones, and you have ovulation. Now, I talked about this, and I left this with you at the end of lecture. Negative feedback. How does hormonal contraception work? Anyone explain that? Because it's pretty important, because most sexually mature women are going to take some form of hormonal contraception, except the ones who use IUDs or barrier methods. Any idea? Can I lead you in? Because you should be able to explain this to a patient. All right. And then possible side effects. Okay, let me lead you in. You're taking synthetic estrogen and a synthetic progesterone. That's usually what's in them. Okay. There are some forms of hormonal birth control that just contain progesterone, because the progesterone has a protective effect. You don't want to take just pure estrogen. The synthetic hormones, as you start taking it, whether you take it as a pill, an injection, an implant, a patch, NuvaRing, whatever, you get the hormone into your body, levels of those synthetic hormones rise in your bloodstream. Your hypothalamus can't tell the difference between the real one your body makes and the synthetic one. Negative feedback dictates that when it gets high, what happens? Body wants to bring it down. So the hypothalamus is going to respond by stopping production of its releasing hormone that affects the gonads. So what is the 2-letter acronym that comes in front of the RH? GnRH. It's going to stop GnRH production. When it stops production of that, The pituitary stops production of these hormones, FSH and LH. Got the command from the general, right? Without FSH, you won't mature that egg in the ovary. One won't be selected to mature. And without LH, you won't ovulate. The egg is not maturing and you certainly can't ovulate it. Now you might say, Dr. Barbeau, but if you have no LH, you're not producing your own estrogen. It's okay. You're taking the synthetic form of it and your body's going to treat it like the real thing. So that will be your source of estrogen. It's important to explain this to people because I tell you, I am a reproductive physiologist and endocrinologist, and I see it all the time. And I see it in the news, and I see people who are in high positions screwing it up, not understanding how hormonal birth control works. I've seen it published in news articles where someone says, birth control causes abortions. I'm like, on what planet? Okay. Hormonal birth control works by stopping egg maturation and ovulation. Can't get pregnant if the egg doesn't mature and leave the ovary, right? There's no way it can cause an abortion, not hormonal birth control. That's why it's called contraception, against conception. So make sure your patients know that because they're going to come in and they're going to say things you won't believe. I heard that it causes abortion. All right. And women have all these little dead embryos in their uterus. And you're like, no, come sit with me. We need to have a talk. You need to understand how it works. Okay. I will get to contraception at the end of the semester, but you're going to see it and you're not going to believe your ears because people don't understand biology 101. Okay. Any questions about that? That's something I would hope you'd be able to explain to a patient of yours. Okay. Now, studying everything I've just talked about, it's a pathway. So I've got a blank flow diagram and I got a key. And the best way to do it is print it out or have it on your computer where you can mark up a PDF with a stylus. And you're going to have 5 releasing hormones, GnRH. And I want you to practice this, GHRH, CRH, TRH, and PRH. All right. And then you have growth hormone inhibiting hormone, and you have prolactin inhibiting hormone. And then you follow and say, well, what does the pituitary do in response to that? And to that, and to that, and go on. And then you say, what is the body's response? This is how you master half of this chapter. If you can do this from a blank like this and fill it out, you got it. Okay? You got it cold. This is the only way to learn it. All right, is to practice writing it out. And of course, I've got the key. And when you look at that, you'll see, oh yeah, that does look like what Dr. Barbeau just kind of filled out on several slides worth, but it's all on one page, the entire endocrine system, not the disorders, but the entire endocrine system. I had to learn the endocrine system because my PhD was in endocrinology and I didn't know it either. I was like, I talked to my advisor, I said, how the hell do you have this memorized? He said, it's been years and I've gone over and over and over and eventually it sticks. And that's when you're studying physiology and pathways, if you go over and over and over, eventually it will stick and it'll be there. And it needs to be there because trust me, I just sat down with Dory Weaver this week and we went through some case studies and you don't have anything in front of you. We didn't have anything in front of us. And I told her, I think I mentioned it to people in lab. I don't know if I did here. She teaches pharmacology. She's got a PhD and master's and all these degrees and those continuing education. She's a pretty smart lady. We sat down and we looked at 2 or 3 case studies and it's all on computer. And we were like, you're supposed to choose the correct treatment or test to run. And some might have 3 blanks to answer, some might have 4. And we went around, it took us a good 10 minutes to, between the 2 of us, say, well, if they're retaining or losing sodium, then, then they're blah, 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 blah. And they said, but then you want to look at it. And we went back and forth bouncing off each other. And it took us 10 minutes to get it. And trust me, she has her stuff down and I have my stuff down. You have to learn these things because when they test you in nursing program, it's going to be like that. All right. You have to understand the pathways to understand the disorders. And if you understand the disorders, you understand the treatments for them. And so I'm teaching you the pathway. I tease you with some disorders, okay, and some drugs. That's just to give you a little incentive for what you're going to face in nursing school. But you got to have these down because you're not going to be able to look at any notes when you're doing this stuff, just like we did. And if we have to think about it hard, you definitely have to work on it. That's not discouraging you. It's encouraging you. All right. Okay. Hormonal regulation is through negative feedback, just like hormonal birth control. When the synthetic levels of the hormones rise in your body responds to try and shut down the normal pathway. That's how that works. All right. So page 265, 266, that's a one-page read basically. If blood levels of a hormone are too low, the hypothalamus will increase the releasing hormone. And the pituitary will respond in kind. All right. If the hormone levels are too high, the hypothalamus will stop secreting its releasing hormone, or in some cases, it'll have a specific inhibiting hormone and it'll secrete that. And the pituitary responds in kind because the body wants to keep those hormones within a certain narrow range. So, can you think of a hormone that is not regulated through negative feedback, but by positive feedback? And go. Prolactin. And what's another one? So that's what the pituitary can release. What is something that hypothalamus releases that is controlled by positive feedback? There's only one example I gave. Chapter 1, oxytocin. Okay. But by far and large, most of the hormones are regulated by negative feedback. Okay. So testing this, let's do this little game. So if the hypothalamus senses that growth hormone in the blood is too high, what does it do? So what will the hypothalamus do if it wants to bring the growth hormone down? Huh? Yep, it'll secrete growth hormone inhibiting hormone, and it will stop growth hormone releasing hormone. See, now it's doing two things. Most of the hormones, it'll just stop its releasing hormone. Now, if the pituitary doesn't get the signal to release growth hormone, it will stop growth hormone secretion. All right, simple. Now, the opposite scenario. Now, growth hormone is too low. The hypothalamus now does what? Increases growth hormone releasing hormone. And that makes the pituitary increase growth hormone secretion. All right. So negative feedback, now that you've learned it, it's quite straightforward. It is. It's a very fast pathway. Now, this will explain hormonal birth control. If the hypothalamus senses that estrogen or testosterone, or I'll even add progesterone, any of those hormones are sex hormones, is too high, what does it stop secretion of? Yep. Okay. Now, without the signal or command of GnRH, what does the pituitary stop secretion of? Stops LH and FSH secretion. And without the LH, the ovaries or testes won't produce their sex hormones. So the ovaries won't make estrogen. Testes wouldn't make testosterone. Without FSH, ovaries won't mature an egg. Testes won't mature sperm. So this is how hormonal birth control works for women. You're taking a synthetic level of estrogen combined with progesterone, and this exact thing happens right here. Now, it follows then, if it has that effect on women, what happens if you take synthetic testosterone, like anabolic steroids? Oh, because some people abuse anabolic steroids, and I do have an anabolic steroid abuse clinical act, and we'll look at it shortly. But I want you to think about it. We know that if you take a synthetic sex steroid, the hypothalamus will stop GnRH, the pituitary stops LH and FSH. So without LH, testes won't produce their own testosterone. But if you're taking the synthetic, your body treats it the same. Now here's the thing. If an organ or a tissue goes without stimulation for too long, it will shrink, it'll atrophy. Yes, the longer you're on hormonal birth control, your ovaries kind of atrophy because they're not being active. And then if you come off it, they should take, it might take a week, it depends on your age, it might take a month for them to become active again and start doing what they normally do. Testes will do the same thing. The longer someone abuses anabolic steroids, their testes shrink. That is a real thing, okay? So that's one of the downsides of using anabolic steroids is your testes shrink. The other thing is, well, there's lots of things. So let's look at that right here, because that's the negative feedback pathway we were just looking at. So let's make this, where have I got here? Can I make this bigger? Yeah, so you can see it. Actually, it's a touch screen. What the hell am I doing? Okay, anabolic steroids are synthetic androgens, promote protein synthesis, tissue growth in muscles. Use of these drugs, and it says bodybuilders, but it's spread out beyond bodybuilders at this point. Can cause a number of undesirable side effects because of negative feedback. Because the liver and fat tissue can turn androgens are very tough on the body. Testosterone is tough on the body. High levels of testosterone increase your risk of cardiovascular problems. Your LDLs will increase, your triglycerides will increase, all that stuff, okay? So what the body does if there's high levels of testosterone, it'll convert it to estrogen. That's what our ovaries do. We produce testosterone first in our ovaries, and we have an enzyme in our body that converts it to estrogen. But that will happen in men if their androgens rise too high. And what happens if they are producing estrogen from that is they'll get female-like breast growth. It's called gynecomastia. So some man comes in and he's got female-like breast tissue. His testes are smaller than they should be. And he's having a problem with his wife conceiving a child because his sperm production stopped. You might want to ask, and it looks like it might be a bodybuilder. You might want to ask, be honest with me now, are you taking any synthetic androgens, anabolic steroids? Because that's a symptom of this. What you're experiencing is a symptom of that, okay? So the testes can atrophy, okay? You'll have erectile dysfunction possibly, which means you have a difficulty achieving and maintaining an erection. It can, if you're prone to it, start male pattern baldness. And testosterone can close your growth plates prematurely. So a young person taking anabolic steroids are at great risk, all right? Women who abuse anabolic steroids can become masculinized. Their vocal cords change and their voice becomes deep. And once it becomes deep, it's never going back, okay? It's a permanent change. And then, of course, roid rage and all those things. So I go over this because you're going to see it as nurses in men and women and possibly young adults. All right. And that's a problem that has to be addressed. Okay. So let's go back to this. Okay. Negative feedback. The hypothalamus senses low thyroid hormone. It's going to increase secretion of what? It's real easy. It's one letter followed by RH. And the one letter stands for T. It'll increase that. And then the pituitary increases TSH, thyroid stimulating hormone. Okay. Now, I don't have adrenal stimulants, but let me check the time here. If the hypothalamus sensed that cortisol levels were rising in the body, it's because a person was prescribed and is taking a synthetic cortisol called a glucocorticoid, like prednisone, dexamethasone, or something along those lines. It gets high in the body, right? And the hypothalamus responds, we got to get that down. So the hypothalamus would stop secreting its CRH. The pituitary stops secreting its ACTH, adrenocorticotropic hormone. And you will have side effects. And so this was a reading assignment before, but we'll go over again. So glucocorticoids, they're called that because it's a stress hormone. And when you're under stress, your body releases its glucose sources as a reserve. And so that's why they're called that, okay? Hydrocortisone, the stuff that you can put on your skin. Prednisolone, that's another version, okay? They're very useful, but they come with side effects, which you must make sure and explain to your patient. Various inflammatory conditions is used to treat. It can also suppress the immune system in people who are receiving transplants, but they actually have really powerful immunosuppressant drugs. But yes, it'll keep your immune system from attacking your own tissue or donated tissue. But if levels of these synthetic glucocorticoids rise, you're going to have negative feedback step in. Hypothalamus stops secreting CRH, pituitary stops secreting ZIPs. Anytime an organ goes without being stimulated, it's going to atrophy. As long as you're on these synthetic glucocorticoids, your adrenal cortex will atrophy. Okay. So suppression of this can lead to atrophy of the adrenal cortex, and it can persist for a while. Now, I don't know how much you know about them. They're so commonly prescribed. For all I know, you might have been prescribed them for something, but you don't stop taking the synthetic glucocorticoids cold turkey. You know why? Your adrenal gland has shrunk, and it's going to take it a while to come back online. So you're supposed to taper down the doses of it over a certain period of time to give your adrenal gland some time to come back online and start doing its thing. All right. Have you heard these about synthetic glucocorticoids? All right. It's very common. So commonly prescribed, you're going to encounter it. And it's things you got to tell your patient. One of the things you're going to have a problem with patients is patient compliance. They don't do what you told them they need to do, or they don't do it the way you've told them to do it. All right. You must taper this down. Oh, I just got to stop. You're going to be in for some problems if you don't do it this way. There's a reason for it. Okay, so we've covered a whole hell of a lot. Now we get to have the fun of endocrine disorders. And I've only included the ones, there's one in here that may not be that common, but most of them I've included are the ones you're going to see on a regular basis because they're that common. I used to see them in animals. That's how common they are. So this is the interesting stuff. All right. And I do have a clinical app on pituitary gland growth hormone disorders. I said too little is a problem, too much is a problem. All right. So if you don't have enough growth hormone secretion from the pituitary, you're not going to grow as much. If it happens when you're an adult, the disorder, the drop in growth hormone happens as an adult, you're not going to have a severe effect, but your tissues might have a hard time healing and replacing themselves. But if you're young and you have too little growth hormone secretion, now you're going to have a big impact because, well, you're supposed to grow. Okay. So what will happen is it's called pituitary dwarfism. There's different types of dwarfism. And don't call people who are little people dwarfs. They hate it. They're little people. Okay. They could have achondroplasia, which is a genetic condition where their bones don't turn cartilage to bone correctly. But if it's hormonal, and how do you find out? You run a genetic test and you run a blood profile for growth hormone. And if you find that the genetic test, they say they don't have achondroplasia, but on their blood panel, their growth hormone is too low, ding, 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 you know what it is. We don't have these growth hormone disorders as common, or they don't go undiagnosed as common, because what does every parent do with their child? They mark their growth on the door jamb, right? And they're supposed to be, if you're seeing a pediatrician, you have access to healthcare, you pick up if your child is too low or too high on the growth spectrum for their age. All right, so you catch it, they say something's not right here, and then you go see the pediatrician, you do tests and you nail it down. If they found not enough growth hormone, you take the synthetic one that's prescribed, the FDA approved, and carefully under physician supervision, you monitor that child's growth. Now, too much growth hormone causes problems. I've explained some of them. If it starts excess growth hormone when you're a child, it's called gigantism. Okay, and that is a problem because they grow too much for their body's ability to deal with that. So they grow tall, they put on more muscle mass. If their joints aren't mature yet, and they're not when they're children, it can put tremendous strain on them, cause permanent damage. You're at more risk of joint and tendon injuries and other problems. All right. So again, for the reasons I said, in the US, because if you have access to doctors and you find your child is growing a lot more than they should for their age group, you take them to the pediatrician, you find out what the problem is, and they'll have some growth hormone blockers, which must be carefully monitored of that to make sure you're not giving too much of it. When the condition starts when you're an adult, too much growth hormone, it could be a pituitary tumor. So when I think of acromegaly, I think of the A and I think of adult. Now, that is a problem too, and it will reduce your lifespan because even though your growth plates are fused, so you're not going to grow any taller, so the bones don't lengthen, but they grow outward, they thicken. That will be devastating to your joints, okay? So at your joints, you're going to have thicker, heavier bone, putting more pressure at those joints. And the bone thickens everywhere in your body, sometimes leading to mobility problems. So this is a woman who was diagnosed in adulthood, and her face is changing because the bones in her face are thickening. All right. So I've heard it's a very painful condition and it can shorten your lifespan. Now, you guys probably never ever followed Andre the Giant, which was this wrestler, but he was a classic person who had this. He was in The Princess Bride, which is a pretty classic movie. He had acromegaly and he did die prematurely because of it. Caused a lot of, he said he was in a lot of pain all the time. So you catch these, you got to treat it so it doesn't progress to the point where you have a problem like that. Okay, adrenal gland disorders. These ones you're going to see. Okay, definitely. So the adrenal cortex responds to pituitary adrenocorticotropic hormone in the following 3 ways. It will make a small amount of sex steroids like estrogen and testosterone. And you're like, oh, if I'm a woman and my adrenal gland is producing testosterone, is that a concern for me? No, because during your reproductive years, your ovaries are producing so much estrogen, it will mask any effect that that little bit of testosterone has. But when you go through menopause and you don't have that estrogen anymore, testosterone can have its effects, all right? After the loss of estrogen from the ovaries, women feel the effects of that little bit of testosterone. It can change their triglycerides, their LDL to HDL. They might develop some thickening of facial hair. Trust me, you have fine hairs on your lip, under your nose. They're very fine. They're probably white or blonde or whatever, but they can thicken under the influence of testosterone. It's called hirsutism. So there are things that can happen to a woman after menopause because of this. Men, are you worried about the little bit of estrogen coming from your adrenal gland? Well, men don't have a cutoff point called menopause. They produce pretty high testosterone, and as they age after 40, it declines, but it doesn't stop. So they really don't have any impact of this. Now, this hormone, it's called a mineral corticoid because minerals equal salts. Minerals are salts. This hormone is not secreted by ACTH stimulation. We're going to cover this later on in the cardiovascular chapter. So, but it is produced by the adrenal cortex when another hormonal signal stimulates it, but not ACTH. Okay, so ACTH, I'll put here, doesn't control this. Okay, if your blood salt content changes, that's what will happen. But aldosterone, it's got an A, it's got an L, it's got an S and a T. If you rearrange it, it spells salt. And aldosterone tells your kidney tubules to increase salt reabsorption. I lost my pen for a second. There we go. So first, at your adrenal glands, this hormone goes down to your kidneys and it tells you to retain salt. The salt goes back into your bloodstream. So salt leaves your intestinal lumen and crosses into the bloodstream, crosses a membrane, right? The intestinal lumen. Where salt goes, what follows it like a puppy by osmosis? Water. If you retain salt, you retain water. That's a principle. All right. So the other thing, and this is the important one we're getting to, is this. Glucocorticoids, cortisol. All right. I don't know if I have it down here. It's your stress hormone. That increases blood glucose because it's a stress hormone. And when you're stressed, your body releases reserves. Okay. It increases blood glucose and it's immunosuppressant. Or you can say suppresses the immune system. Okay. That's what cortisol does. And I already talked about the negative feedback on taking synthetic glucocorticoids. So we don't need to go there. But it does increase blood glucose. So we're going to talk about a disorder of cortisol secretion. I got the time, so I'm going to do it. Now, before we get there, we're at the adrenal gland. We talked about what the cortex does, but we didn't talk about the medulla. Well, I've mentioned it before, but under sympathetic response, the hypothalamus stimulates the middle or medulla of the adrenal gland to pump out, sorry about this, epinephrine. Now, I'm not going to go over it now, but we now know what epinephrine causes the body to do and the receptors it works by. So don't forget to review that for on the next lecture quiz. Okay, cortisol disorders. So Cushing's disease is known as hypercortisolism, but they just call it Cushing's in clinical settings. It's excess cortisol. So when I think of Cushing's, the C, I think of excess cortisol. So, and I do have a clinical app online, and I might go back to that, but it could be because your hypothalamus is pumping out too much CRH, or your pituitary is pumping out too much of that. So that'd be a problem in the brain. But more commonly, it's an adrenal gland tumor. And so the presentation of someone with Cushing's, because you're going to see it, I guarantee it, it's very common. Okay. Hyperglycemia, which is high blood glucose. Okay. Left untreated, high blood glucose can cause problems. I'm not going to go into all that right here, but it affects your blood vessels, all kinds of things. All right. So you got to get that under control. The other thing it causes is hyperlipidemia, high blood lipids. Okay, so that's increased fatty acids and triglycerides. Now, we talked about those lipids in the metabolism chapter. In the metabolism chapter, that is done. We did that exam, okay? But hold on to that stuff. When your body is stressed, it's going to release reserves because your body's stressed. Release the glucose, release the fats, we need them, okay? We're stressed, and that's what your body's doing. Left untreated, high blood lipids can cause cardiovascular damage, all right? Your arteries can be filled up with cholesterol plaques and cause problems. So these have to be treated. You can't let this go untreated. Hypervolemia is high blood volume. You are retaining water. Let's see what my next thing is so I don't write into it. Okay, I got, so you retain water. So you have swelling in the face and abdomen. Okay, and that's what this is supposed to show. People will gain weight. If people gain weight rapidly, it's usually you're retaining water. All right, and here's a kid who had to be treated with glucocorticoids for some inflammatory condition in his body. But the problem is the high levels of synthetic glucocorticoids, the body can't tell the difference. It thinks your body's got high cortisol, and a patient can have treatment-induced Cushing, and that can happen. But you're between a rock and a hard place. You've got an inflammatory condition that's making your life miserable and can cause problems. You gotta get on glucocorticoids and get that inflammation under control. But the drug has side effects. Welcome to pharmacology. Okay. So you have a patient who's got an inflammatory condition. You're being prescribed glucocorticoids. You got to take it according to this treatment regimen we've given you, and then you got to taper it down after this time. But expect that you might encounter things like this. Your blood glucose might be high. What happens if you've got someone who's got an inflammatory condition and they have diabetes and they have to take a synthetic glucocorticoid? They have to really watch their blood glucose. All right. So there's all these things. And so this kid got prescribed synthetic glucocorticoids for an inflammatory condition, but it resulted in them puffing up from that. All right. That's common with long-term synthetic glucocorticoids. So you want to let your patient know, and then let them know if you're experiencing some of these things and it's really bad, let us know. All right. Okay. Hypertension happens if you're retaining water. If your blood volume is high, you have high blood pressure. So what happens if you have a patient who has an inflammatory condition and they need to take synthetic glucocorticoids, but they also have high blood pressure? All right. There's things you can do. I'm not going to get into it. You can put them on diuretics and other things, maybe a beta blocker while they're taking this. It gets complicated. I'm not doing that to you here. Okay. But these are things that as a nurse, you're going to have to consider. I mean, and the doctor, of course. All right. This is why patient history is important. You're coming in because their inflammatory bowel disease is really making life miserable for them, and they need to do something about it. You get a good patient history. Do you have, and it might be in their chart already, you have high blood pressure? Do you have diabetes? Do you have whatever? because you need to know that because the treatment might affect those conditions they already have. You kind of getting a feel for nursing? Yeah, that's the reality of it. Okay. We'll talk about this and then we'll leave it at that. But another common condition, I might not get to all of it because I'm looking at the time, is you have too low aldosterone. All right. So aldosterone is too low. Now it's complicated because it can affect cortisol, but I'm not going to talk about that right now because it's too much. All right. And there's a clinical app online for that. But again, it could be an adrenal tumor. It could also be an autoimmune disorder. But the presentation, if aldosterone increases salt retention, that means it goes back into your bloodstream. It will increase water retention. And that will increase your blood pressure. If you retain salt, you retain water. If you retain water, your blood pressure goes up directly. If you have too low aldosterone, what would happen? And I might not write it down. I'll write it down on Friday. Let's just talk. If your aldosterone is too low, you can't retain salt. Hyponatremia, the symbol for sodium is Na, right? So what happens is you pee salt out in your urine. Water leaves. Oh, sorry. I gave it away, damn it. If you're peeing out salt, I'll get to this in a second. Your potassium levels will increase, and the symbol for potassium is that. I'll talk about that on Friday. If you're peeing out salt, you're going to be peeing out water. You're losing water. You're dehydrating, basically. If you're losing water, your blood pressure drops because you're losing water. All right. If you lose a lot of body water fast, it's called anorexia. It's not because you're not eating, it's because you're losing body mass because you're losing water. Anytime someone loses body weight quickly, it's probably they're losing water. And then lastly, because of the cortisol fraction of that being low, you'll have a drop in blood glucose. If the person has this and diabetes, now they're in trouble. And then lastly, your skin bronzes. Your melanocytes overstimulate the secretion of melanin. So we'll write all these down on Friday and explain it, but I just wanted to have a talk, see what would happen. All right.